Dr. Carrie Jones, welcome, welcome. I'm so excited to have you back with us today.
Oh my gosh, I'm excited to be back. This is gonna be a good topic.
I know, and I'm so excited to really talk about, so we were just chatting for a second, but all about progesterone. So in my experience, at least commercially, what people are hearing, the women out there especially, it's all about estrogen, right? We talk about that so much, the effect on the body. Everybody's always like estrogen dominant or what have you, but progesterone doesn't get enough of a conversation, in my opinion. Would you?
I know. And it's
And
it's
she's
like
I mean,
she's like the calming, relaxing, soothing, everything's gonna be okay hormone. And who doesn't want that? We could use that right now.
all use, I know. So it's like that rest, relaxation, feel good hormone. And we talk so much about like estrogen. And I feel like we still don't even actually always talk, you do, but not the whole world, about the relationship of the two as well. So if we could start with like a basic introductory for anyone who's new to hormones on like a little bit more about progesterone, like maybe signs and symptoms of an imbalance of progesterone in the body and maybe conditions, just so people know like this might be, let me keep listening or not for myself.
Right. Like I think I could use some relaxation.
Yeah.
That's wonderful. So progesterone got its name because it's progestation and it's all about primarily helping to maintain a pregnancy. It keeps the inside of the uterus big and fluffy. It nests. It like goes to Home Goods and buys all the pillows and the throws and like puts them around your uterus so that when the embryo comes down, like it can attach and grow and you can grow a human. Now, a lot of women listening are like, oof, not looking to get pregnant. That's so not of an interest of mine. Progesterone does a lot of other really cool things too. So that's why you and I love it.
Mm-hmm.
Progesterone only comes out after ovulation. So the key, do you make progesterone? Well, do you ovulate? Do you feel yourself ovulate? Do you feel like the change in your mucus is like in the sort of middle of your cycle? That's indication you're going to ovulate. Do you get like twinges or cramps in the middle of your cycle like you ovulated? Can you tell? So once you release the egg, that's ovulation, you start to pump out a lot of progesterone. And so then what it does is, like I said, is it does help the inside of the uterus. And it can really make a difference in heavy periods, clots, fibroid formation, polyps. Now, yes, estrogen, especially estrogen excess, can make those things grow and be worse also, but it's progesterone that's the counter. So you may actually have completely normal levels of estrogen, but like bottomed out 0 levels of progesterone. And that's actually the problem. And if you don't feel calm, and if you're feeling more anxious, and if you can't sleep, especially as you get closer to your period, all sort of keynotes for it's time to look at progesterone.
Yeah. And I think it's so important you mentioned, like, so many people where it's only talked about is IVF or fertility processes. And it's so important in every stage of life, really.
Yeah.
We don't talk about it, but so outside of the lack of ovulation, what else might cause low progesterone for somebody or contribute to that level?
What contributes to low progesterone? So a big one right now, which will really hit home for a lot of people, is stress.
Yeah.
So your stress hormones, cortisol, adrenaline, which is epinephrine, they all feed back to the brain and they say, ooh, like she's kind of stressed out. Let's not ovulate this month. And that therefore you don't. It's a protective mechanism. But the like downstream sequelae is that we don't make progesterone either. So stress is a really big one. And I think a lot of women can understand this too, because maybe prior to the pandemic, they've had something really stressful in their life, whether it was finishing a project, graduating from a program, going through a divorce, moving. And they're like, gosh, my period just really went crazy in that time. I either skipped periods or they were really heavy or my PMS was really bad. And it took a few months and now it's back on track. And now, of course, we know with just stress in the current world situation, I've had a lot of women reach out to me, I'm sure you too, to say, is this normal? Like my period is suddenly so heavy, or my period came a full week earlier. It came a full week late. Like, what is this about? Like, your stress hormones do play a role.
It's that elephant in the room that no one wants to address, right? It's easier to tell someone you're stressed or the stress is contributing versus them taking ownership a little bit of that and finding ways to stress manage.
Right. Yeah. Because the brain is ultimately just trying to protect you. But like I said, unfortunately, it comes at the cost of progesterone.
Yeah. So that's so interesting. So they need to address stress. And another important fact, kind of digressing a little bit, but so we use the Dutch test a lot in practice for testing hormones. We always, the more I do this, the more I ensure somebody is testing ovulation to make sure we're catching a proper sample there. Cause I do feel like a lot of people don't. And then you're like, I don't know what's valid or not necessarily on this test. Did you necessarily ovulate? So I think it's important that if you are working with a provider or even a patient of ours, and you're doing a Dutch test, to make sure, unless obviously you're menopausal, that you are ovulating when we catch that, to have the truest picture of what's going on before somebody starts throwing a bunch of supplements or something at you and messing with.
I actually have a good story about this. A friend of mine I'm not in practice. So she went and saw a well-known OBGYN who leans into functional medicine. And she texted me after the fact and she said, she drew my hormones today. And I said, okay, like what day of your cycle are you on? She said, I'm on day 8. And I said, all right, well, what hormones did she draw? And she said she drew like estrogen, progesterone, and then, some other testosterone, thyroid. And I said, why did she draw progesterone? And she was like, I don't know. She said she was going to do a full hormone workup on me. I was like, oh no. And so fast forward, she gets the results back and she's like, Carrie, I have really low progesterone. It's like near 0. I'm like, I know, because on day 8 of your cycle, it's supposed to be near 0. You haven't ovulated yet. So I agree 100% with you that if you want to really, you're paying the money for this. So if you really want to know specifically, find out when you ovulate, do those ovulation predictor kits, see if you're going to ovulate. And then generally we say count forward 5 to 7 days and do your hormone test then, your estrogen, progesterone then.
I see that very commonly more in the traditional field, but also if it funnels in a functional medicine practitioners are relatively new to the functional medicine world and testing all of the time. They're like, oh, my PCP, my OBGYN, somebody drew my blood panel and they're testing my hormones, but they never advise them what day of the cycle, make sure. And it just kind of is wild that still goes on,
And it's unfortunate because it's just physiology. It's not even a weird functional medicine thing. Like we're just following the physiology of your hormones. Like FSH should be drawn day 2 or 3, not randomly, progesterone should be drawn in the second half of your cycle. Yeah. So these just little keynotes, just following basic physiology that can be really helpful.
Absolutely.
Just more accurate.
Yeah. And I think it's important to note too, for everyone listening, if you're of menopausal age, right, having the low progesterone is normal. So it's more about the rate. So maybe you could just touch on that so that everyone who is, menopausal, postmenopausal, even perimenopause aren't like, oh, well, I have it, this is abnormal.
Right. Right. So as you head into perimenopause, so when you're in that transition state, your ovaries generally don't want to ovulate as much anymore. Your follicular health is, going down, you're losing your follicles. So you don't really ovulate, and therefore you don't really make progesterone like you used to when you were younger. And then once you're fully menopausal, 12 months, no period, you don't have those follicles to make progesterone in the first place. So you go from really robust levels of progesterone to what we consider post-menopausal levels of progesterone and estrogen. But it is the levels are very low. They can be almost shockingly low. Mm-hmm. However, perimenopausal and menopausal women often feel better or less symptomatic when they get a boost of progesterone, when they go on a little bit of a amount of progesterone that's, good for them and for being in menopause. So it can still, just because you're in the menopausal range doesn't mean you're still not going to have symptoms.
Yeah. And so I have a question. So jump around. This was going to be a later topic, but we're on the topic. So there's still a lot of controversy, in my opinion, about hormone replacement therapy, right? Mm-hmm. So and obviously this is a very individualized thing, you want to know family history, all of that. But like you just said, right? Postmenopausal women getting hit of progesterone can really change their mood, how their whole body is really functioning. So in whatever way you want to address that, like, what is your opinion on BHRT and maybe forms of progesterone and taking?
So
best.
For sure. I am a fan of bioidentical hormone replacement. Now, remember, hormone replacement is a big category. So like your thyroid medication is considered bioidentical hormone replacer, right? You're replacing thyroid. DHEA, testosterone, estrogen, progesterone, those are all hormones and they're all hormone replacement therapy. But just like you said, most everybody is really honed in on estrogen and progesterone when they use those words. So for the right woman, depending on, labs, risk factors, symptoms, et cetera, I am a big fan of using HRT but it doesn't mean I'm automatically putting her on estrogen. Maybe we start with progesterone. Maybe she needs the androgens like a DHEA or testosterone. So I actually had a DM recently of a woman who said, I can't take estrogen. Estrogen gives me migraines, even in menopause. So I just do progesterone, and it's made a world of difference. Just having that extra progesterone took away almost all of my symptoms. And I think that's wonderful. So with progesterone, there's a couple. First of all, there's the kind your body makes, which is truly progesterone. And then there's the synthetic form, which is called a progestin. And that's like what's in a birth control pill. That's the synthetic form of progesterone. Or even in some menopausal hormone therapy, there's progestins as an option, like it's called Provera. So if you're sticking just to progesterone, we have topical, so like a cream. You can use it vaginally, which means you can use it on the outside of the vagina or up inside the vagina, but just make sure it's specifically for the vagina. Don't just take a cream and just think you can put it up there. You can take it as a pill, so you'll swallow it. You can take it as a lozenge, which is called a troche, so you'll put it under your tongue or on the side of in your gum and just let it dissolve. So there are a few options as it relates to progesterone. In the US, it is over the counter as a topical cream. You often can find it at a variety of sites or at a variety of stores, and they generally cap out at 20 or 25 milligrams per dose. When you get it prescribed or compounded, obviously the dose can be much higher. For example, the oral pill that's commonly called Prometrium is 100 or 200 milligrams per capsule. So the dose can really vary depending on your need.
Yeah. And so a lot of people who do the creams, right? It depends where you're putting it. I find that it's not always absorbed in the same.
So that's really controversial because people have very staunch opinions on where you put the cream. I'm very staunch in my opinion, but I'm open to education. So progesterone is extremely lipophilic. It loves fat, like loves it. Like you think estrogen likes fat? No, progesterone likes to hang out in your adipose cells, loves it. So if you rub it in your thigh, if you rub it in your breast tissue, if you rub it in your belly, anywhere that there's just being female, right? You just maybe have extra lot and you've got some adipose there, some fat tissue. It oftentimes, we can't guarantee that it's not going to get out. Like the fat, it's gonna hang out where it likes to hang out, which is in the fat tissue. So it may get into circulation in peaks and valleys. Like you may get a lot initially, and then it kind of just sort of peters out. It really kind of depends on the person. So I'm a bigger fan, knowing that progesterone likes fat tissue so much. I like the thin skin. So I suggest putting it on inner wrist, the elbow, behind the knee. And so anywhere that you have where you can see veins generally, or just that thinner, obviously there's still going to be some adipose tissue there, but it increases your chance it'll get into circulation. I think this is what I think, knowing what I know about progesterone as a molecule and that it likes to hang out in adipose cells.
I actually didn't know that. See, learned something. Great.
Yeah. No, estrogen is as well. Estrogen, they're all lipophilic, so they like fat cells. Progesterone likes it the most, though.
Interesting. Yeah. You know.
Now you know. So that's why I'm like.
I mean, I always know I am also a believer in the thin tissue. I maybe didn't understand the mechanism as to why. So that's always, you see, I like talking to you.
No, if like, let's say somebody's using progesterone on their breast tissue for something specific, breast tenderness, let's say breast pain and breast tenderness, and their practitioner said, rub cream, progesterone cream where the breast pain is while we're getting it evaluated, or like whatever reason. That's different. That's that's right to the source, right? You're like, have breast pain, apply cream to breast pain. Got it. Whereas if somebody's just like, I have hot flashes, I have night sweats, I don't sleep, I'm anxious, and you want a more general progesterone approach, that's when the thin skin is more what I recommend.
Actually favorable. Interesting. So another thing I see in my practice a lot, with more my perimenopause, menopause, also though my, birth control takers, is the sleep disruption and the GABA connection with progesterone. So if you can talk to us a little bit about okay, so quickly, what is GABA? And also how does progesterone levels impact our quality of sleep? Because that is huge. And I find that potentially supplementing, with some GABA and working on or things that increase progesterone is very helpful. for them?
So GABA is our main inhibitory neurotransmitter in our brain. So inhibitory meaning calm down. It calm down, relax, anti-anxiety, stop. That's what GABA does. Progesterone, when it breaks down, so you make progesterone, it has to go somewhere. The body starts to break it apart. One of the molecules it breaks into is called allo, A-L-L-O, not aloe the plant, but A-L-L-O. Allo can cross up into the brain and it will bind to GABA receptors and activate them. So not only is GABA binding to its own receptors, calming and relaxing, the allo from progesterone binding to GABA A receptors, also calming and relaxing. So GABA receptors through your lifetime as a female get a lot of love and support from GABA itself, which you make as a human, and progesterone. Then as if you don't ovulate, or if you are perimenopausal and not ovulating, or menopausal and not ovulating and not getting enough progesterone, they tend to report worse sleep or even, increased anxiety because they don't have the calm, the relax, the stop from the GABA support in their brain. They're missing out on a big chunk of it when they miss out on progesterone. And women often report this getting close to their cycle. They'll say, I can't sleep. I don't sleep as well leading up to my cycle because, of course, progesterone's coming down so that you can start your period. And I hear this all the time, and you do too. Perimenopausal women are like, I used to sleep like a rock, and then I turned 35 and I can't sleep anymore. What happened? Progesterone is a part of it.
Yep. And I do think there is, and often it can be right, this two-tiered or like two-pronged thing, but cortisol always takes the hit, I think, for a lot with sleep. And even providers, I remember I actually taught a lot of providers this, that I would have assumed maybe knew, but maybe it's not well known, that they're always like, well, it's obviously a cortisol issue. And I'm like, okay, we have to evaluate too, right? Obviously we can always test, but like evaluate, are they on some kind of hormone replacement? Are they on OCPs? Are they menopausal and their progesterone's low? Because that might be what the sleep disruption really is versus elevated cortisol level, right?
Yeah. Or it could be both. They could definitely have elevated cortisol from whatever reason.
Yeah.
And oh, by the way, they don't ovulate. Even think of a woman with PCOS. Woman with PCOS doesn't ovulate or maybe hasn't had her cycle in months and months and months. It's possible she's missing out on a lot of that progesterone as well, and is also reporting higher anxiety, unable to relax, not sleeping as well. And so we associate progesterone, low progesterone, a lot with the perimenopausal, menopausal age range. But goodness, just like you said, we absolutely have women younger, even on birth control, like you said, because they're missing out on a little more of that natural progesterone. So they feel worse, can feel worse.
Yeah, absolutely. And that's part of the reason I always say like test, don't guess, right? Is it gives us more data and what to work with versus just throwing aimless, recommendations at somebody because we once heard cortisol was the truth.
Right.
So that's like a really important thing. Is there any other connections that our population should really be aware of with brain health when it comes to progesterone and progesterone levels?
Yeah, well, one of the other things, unfortunately, it's negative, but I think it's important to know is that, we talk about PMS, but there's PMDD, premenstrual dysphoric disorder, which can be really severe and drastically affect quality of life. And it's what they found with progesterone and PMDD, that it's not that those who have PMDD make less progesterone. They don't. They make, maybe what I make or what you make, it's an appropriate amount. But what they found is those GABA receptors that we talked about, those GABA receptors can't shift. They're like pistons. So think of like pistons moving up and down in a machine. And so when the progesterone, when the allo comes to it or the GABA comes to it, the pistons have to shift to accommodate, like, oh, you're GABA. All right, let's shift and accommodate GABA. Oh, you're allo. Okay, let's shift to accommodate allo. But those who have PMDD, the shifting doesn't work as well as somebody else, somebody who doesn't have PMDD. So they're more susceptible to PMDD because the change in allo or the change in GABA, their GABA receptors can't keep up with. And so I will sometimes have my PMDD patients will say, do you think it's too low progesterone? I'm like, well, actually, it's an issue as far as we think in the GABA receptor itself. So these women might do well doing like a low steady state of progesterone all the time. Sometimes you say, oh, just give progesterone in the second half of their cycle. But with PMDD, just doing it maybe more continuously, along with other things, can be really helpful for them. And so speaking of like brain, since PMDD, a lot of mental symptoms come out of it, that I want them to hear this and be like, oh, GABA receptors. Okay.
So interesting. And no one's probably talking to them about that, So
Probably not. I mean, a lot of PMDD treatments are, of course, to go on an SSRI, an antidepressant, which fair enough. And there's research to show that it can be really helpful, especially leading up to the period. But we know there's other things that can be helpful as well.
interesting. And so when it comes to women who are having different cycle issues, right? So this is where fertility becomes really important for a lot of women. And but that's where progesterone is often talked about. Do you have specific feelings? I know a lot of us practitioners have been doing this for a long time, but I know it just recently came out in the research to start using progesterone for fertility. And Carrie,
surprise.
yeah.
So
I personally took Chaste throughout my whole first trimester to just out of a little bit of fear and of having a miscarriage. So I did take it and then I dropped it after about 11 or 12 weeks. But what do you see that often be a thing you would recommend or your colleagues are using?
Always. Well, not so much Chaste, but I usually go right to progesterone. So I would tell my patients, as soon as you're pregnant, I need you to call me. I'm going to send you to the lab and I'm going to do 3 things. I'm going to check your HCG. I'm going to check your progesterone and I'm going to check your thyroid, because it seemed like a lot of my patients had thyroid issues, and we know pregnancy really, of course, affects the thyroid. So I'm going to do all those 3 things because I want baseline headed into pregnancy. And if their progesterone was not where I wanted it, then I put them on progesterone. Now, I'm not a midwife. I am not an OBGYN. I'm not a nurse midwife, but I still have prescribing rights that I could prescribe them or put them on progesterone until they could get in to see their OBGYN, midwife, nurse midwife, what have you. And usually they would only have to be on progesterone the first trimester. And the reason for that is that when you are pregnant, your corpus luteum will pump out progesterone until your placenta is big enough and strong enough to take over. And then they do a little handoff in the night. But if the placenta is not doing that, and the corpus luteum can only go right, you can only work so long of a shift, then the progesterone can start to decline, and it can increase your chance for loss due to a loss of progesterone. Obviously, there's a lot of reasons for loss, but progesterone, and I love that the research came out, because we've been saying it I've been in this medicine 23 years, and I'm like, really? Are you serious? You're just now saying it?
No, it takes time.
We've known this.
And it's one of those things. So we just started, I don't think I've updated you on much of this, but we just started doing some different, they're really kind of like discounted, very fixed packages for lab packages. So we have a whole fertility package now. Because my heart just goes out to all of my patients, my friends and family, everyone I see that is struggling either to get pregnant or having miscarriages, because there's so much stuff that we can do and take control of, including, right, how hard is it to say, I went to a doctor and got a progesterone script to see if that helped me prevent miscarriages. So there's just, we're becoming more and more passionate about that, maybe because I'm a new mom.
I love that.
But yeah, we're just trying to help people, because we were realizing we were doing this with so many of our patients, but there wasn't really like a thing to it. So now you can do it, get all the lab work, see what might be not working well ahead of time, or, this is more for people who are thinking about in the future, but this is so important. And we obviously are going to do a Dutch test and see, where is the progesterone? Are you even ovulating? But so that you don't then try to get pregnant and find, okay, now we're struggling. Do you know?
Right.
So very preventative, hopefully, for people, but this is why
I love that.
Listen to this podcast. We will share with everyone who's trying. But that's so interesting. So okay, this one's for Kira. We're throwing her a question, but we have been seeing prolactin issues left and right lately. And I feel like for years of practice, I have not had encountered this level. So everyone's prolactin issues being off, their progesterone connection. So can you walk us through what is prolactin? How does that affect progesterone and overall health? Because I swear it's been this weird influx. Every female is coming to me, and their providers kind of have similar recommendations, but I feel like some stuff's missing in the understanding.
Yeah. So prolactin, like progesterone is your progestation hormone. Prolactin is your prolactation hormone. So it's your hormone that encourages and allows for breast milk production and breastfeeding. And if you are actively breastfeeding, then you would know why your prolactin is high because it's doing its job. The problem is if you're not breastfeeding at all, and yet your prolactin is mildly, moderately, or even severely high, what could that mean? So prolactin is a brain hormone. And if it's worst case scenario, if it's severely high, the first thing you want, and you're not breastfeeding, you do want to get evaluated for a type of tumor in your pituitary called a prolactinoma. And it's generally benign. It sounds super scary and crazy because I'm saying tumor in the brain, but it is generally benign. But that's when your levels are super high. Now, what happens if you're like, well, but my levels are not that high? They're like 20 points over the range, or 15 points over the range, or 100 points over the range. Like, what could that mean? So prolactin is affected by your thyroid. So if you are hypothyroid and you're not well controlled, you will downstream have your prolactin will increase. Your prolactin will go up with high stress. So it can be a transient rise in prolactin with high cortisol, high adrenaline. Your prolactin will go up with low B6. So if you're B6 deficient, then your prolactin will start to go up. So those are kind of your three, aside from breastfeeding or tumor, those are kind of your three big, what would cause a transient. Oh, and low dopamine. If you have low dopamine, because prolactin is under control of dopamine. So if you are deficient in dopamine, you're not able to make dopamine. Some people are on, medications to reduce dopamine for whatever reason. Their prolactin will go up as well.
Yeah. So this is a question I've been wondering. This is not my specialty, but I currently have a patient who is kind of going through that mild elevation, thyroid could use some work, all of that. She's come a far way. They're very concerned and want to put her on like progesterone, all these different things. Or I forget the name of the medication for the dopamine.
Oh, yeah.
Oh my gosh, it will come to me. Right. The whole point is to increase
dopamine. Yes.
Yeah, it will come. I don't know why I'm blinking too, but the point is to increase dopamine, which is, so I was going to piggyback on that. So the question is, with someone who may benefit or we find responsive, right, to increasing their dopamine levels, do we think that there maybe is just a gut health problem?
Yeah, because think about it. Dopamine, as you know, comes from tyrosine and B6. So it's entirely possible they're not either eating the foods that have enough tyrosine in them, or B6 that maybe they're pretty protein deficient, or they are eating. You go through a diet history with them and you're like, but their absorptive abilities are in the toilet, and pun intended. And so, yes, you may find that the gut can be a huge role. And we know that some of our microbiome can make dopamine, right? Like make more than we think. And so it may have nothing to do with their food and not even really absorption, just the microbiome is.
Yeah.
The ones that are supposed to make dopamine aren't.
I was just wondering in that, because I've been working with her a lot on gut health, and a lot of these patients obviously on their gut health. But no one's talking to them about that and like ruling that out prior to let's throw you on meds. So I'm just curious. Yeah, I'm sure
but think about so B6, tyrosine, eating protein, like none of that's patentable. So there's no prescription for that. And so I think it's conventionally, they don't get taught, hey, to make a dopamine, here's the precursors you need. Then you need to be able to absorb them. And then your gut microbiome plays a big role. And none of pharmaceutical companies aren't coming in and educating about that. So I think it's just a lack of education as opposed to they don't want to.
Yeah.
When I find that more when you just explain the basics, well, it comes from tyrosine and B6. They're like, really?
And it seems like there's just there's always going to be, until we all get on the same page, a gap of. So a lot of things you just named are right. Are we looking at a full thyroid panel? Are we looking at the gut microbiome? Like all these, the nutrition, we're not looking at that. Right. So are we looking at these things? So you're like, okay, is the thyroid not optimal, but is someone even checking the thyroid? Like, right. This is
the full thyroid.
Yeah. This becomes a root cause issue of just healthcare, but I digress. I'm gonna get on my pedestal here and talk about everything, but it does. It's like we put this label on and have these medications, what have you, but, this is why, right? This is why the world of holistic, naturopathic and functional medicine, this is dive a little bit deeper, which is why you really need to be working with someone who has that best interest for you, because if you don't get to that root of the problem, right, it's just gonna continue.
Right. It's so true. And to answer actually your original question, because sometimes people, I'm sure your patients are like, well, how does prolactin affect progesterone? Is that right? That's what we're talking about. So when prolactin starts to rise, your body gets confused in a sense and is like, are we breastfeeding? Are we not breastfeeding? Like, what are we doing? And so it throws off ovulation because it's like, well, if you're breastfeeding, I don't want you to have another baby right now. So let's throw this off. And so when you don't ovulate, you don't make progesterone. And it's really tough, can be tough to get pregnant. So whether you're looking at it for fertility or not for fertility, prolactin, even mildly elevated, can just screw up the cycle.
Yeah. Such an interesting, your brain. No, it's so interesting. And I've just been like aghast at how much I've seen it lately. And I'm like, why did I go from never having this come through my office to like, I feel like every human that walks through the door is like, and my prolactin's off. And I'm like, all right,
I wonder if it's I always tested prolactin's always part of my blood panel. And back when I was in practice more in the conventional world, I would have make fun of me, and conventional colleagues make like, why do you run prolactin? They're not breastfeeding, like they're not pregnant. What are you doing? And I'm like, I keep finding it high, and it's in males too. Men can have men have prolactin.
Yeah.
And it's the same reasons: hypothyroid stress, low dopamine, low B6, and low prolactin in men can really cause testosterone problems. Hey, just test it. It's a simple blood draw. It's not expensive. It's not crazy. It's not weird. It's just prolactin.
Yeah. So interesting.
Your hospital, Quest and LabCorp, they can all do it. And so I think it's maybe more education. Maybe more people are like, I guess we should just draw that.
Yeah. So interesting. So everyone listen, ask for your prolactin levels if you're having these issues.
Yeah. Yeah.
Gosh, there's so much. And another thing, so I always knew as a practitioner, this is on me, should have looked deeper into it, but I always knew, right, that women have a higher percent or higher risk rate, I will say, for gallbladder issues, right? Gallbladder issues. And I knew it was a hormonal connection. I actually never knew really what the hormonal connection was that was increasing the risk. So, I assume you're familiar with everything, but what is your like familiarity with gallbladder issues, right? Women's health, progesterone, actually, specifically. I think it's really fascinating.
And we see a lot of gallbladder issues in the big transitions, right? We see it transitioning. So like out of puberty, pregnancy, birth, heading into perimenopausal states. So estrogen adds, to make it really simple, estrogen like adds cholesterol, right? It can essentially contribute to gallstones, gall sludge. It increases the cholesterol and stuff in there. And then progesterone slows emptying. So you want healthy emptying so that if estrogen's packing it full, part of the reason it's packing it full, then you want it to be able to get out. And if progesterone is blocking that, then it's a double whammy. And then because females have more estrogen and more progesterone compared to males, and in these big transitional states, we're prone to more gallbladder problems.
So what would you advise someone maybe that is going, right, they're starting to realize they're going into perimenopause, or they're in perimenopause at this point, but that they can do on these big shifts of hormones? Like, would you recommend that they're testing and working on hormone health, or is this coming more from like, let's just focus on supporting the gallbladder and liver, and going to the bathroom, all that?
Yeah, I think all the above. Why not? And generally, women know if they have a family history of gallbladder stuff. Like, I have a really good friend who's like mom, aunt, sister, like everybody's had their gallbladder out, and she had her gallbladder out, but she could see it down the generational line that gallbladder was a weaker point for them.
Yeah.
And when you ask patients, do the women in your family tend to get their gallbladder out? They're usually like, it doesn't dawn on them that it's something to note, because it's just like everybody does. It's like, yeah, everybody had their gallbladder out. Like, all right, let's try to keep yours.
Gallbladder, I find it so fascinating. Carrie and I talk about this all the time. We're like, it is like the number one thing I see for some reason in my practice that people, especially women, just leave out. They forget that they're like, oh, I don't have a gallbladder. I'm like, well, that knowledge I have, and I'm sure I've even asked, it just doesn't even go and register in so many people's brains that they've had that removal. It's when maybe they're having some stones or something, then they'll be like, I need to work on my gallbladder. But once it's removed, no one's supporting it, right? They're not supporting their fat digestion and absorption. Their doctor's like, you don't need to. It's not even a conversation often. But I find it like, we almost think of it as just like this organ that means nothing. It's so fascinating.
It's so helpful. And actually, I have posted on social, and you have too, about the gallbladder, and the amount of women in the comments and in my DMs who were like, if I'd have known better, if I'd have known better, I would have worked to keep my gallbladder, however that looked. Obviously, in some emergency situations, we're not advocating for that. Get your gallbladder out. But just to like, well, let's try it and get your gallbladder. I mean, I had women that actually wrote me and said I was having stomach pain and the suggestion was get the gallbladder out and I still have stomach pain. Like that wasn't it.
Yeah.
But now I struggle with tons of fat digestion issue, weight gain, hormonal issues. Now I have like more issues with foods because I don't have a gallbladder. I wish I would have known. I'm like, I know it seems to be the just, surgery of choice for any kind of GI stuff. Oh, let's get your gallbladder out and see if that helps. See if that helps. Are you serious?
I see it so often. People are like, when do I go for it? I'm like, okay, if you are someone who keeps having gallbladder attacks, you're full of stones, like you're in agony and you're getting hospitalized and all this, like, okay, maybe that is the appropriate decision for you. But it's like, if you're going, you went through all the GI, gastroenterology route, and they're like, there's sludge. There's so much you can do if you work with someone to figure out why is that there? How can I support it? Whether it's just going to prolong and like keep your gallbladder healthier for longer. Or fix it and kind of put you back into a helpful, balance. Cause I always am fascinated by gallbladder in women. And I always tell them like, there's a hormonal component, all this, but it's always too late. It's just,
I know. Cause usually we're telling them this after, right. They've already had it out. And oftentimes, not always, but oftentimes they've had it out and they still have problems.
Yeah.
It didn't exactly solve what they were hoping it would solve.
Do you find more, and maybe this is just it's so individualized, but I'm just curious, women who you're finding, right? Like maybe I run a stool test or steatorrhea, right? They're pooping their fats out. They're not absorbing well, or they know they're not tolerating fat well. Maybe we don't find too many like crazy wild infections, but they're having GI issues. They're also having hormone, right, issues. Obviously, this is very specific to what we find, but where you find kind of the bigger bang for the buck of starting? Is it with the gut when it comes to affecting their gallbladder, or is it with the hormonal balance?
Because for sure the gut, because the gut has a direct influence on the hormones. And so all the hormones, I mean, like estrogen, how you clear estrogen, even the androgens, DHEA, testosterone, which can turn into estrogen. If they have to, let's say budgetarily, they can only choose one, gut.
Yeah.
We may find in the next 4, 6, 8, 12 weeks that their hormonal symptoms are so much better.
I know. Right. So if you're listening to this and you didn't listen to the first time, Dr. Carrie Jen, we talked all about estrogen basically and how gut relates to hormones. So definitely go check that podcast out from last year. Apparently we're going to have her back on to talk about the androgens and gosh, because I have so many questions about that too. But it's so interesting. And so many people, especially when you have hormone problems, right? They go see their endocrinologist or their PCP and they start there and they might not, right, be experiencing gut symptoms. That's where it really is like a disservice to people, is that we assume gut symptoms means I'm having diarrhea, right? Or I'm having super extension and bloating every time I eat, or reflux, or that's just really what people that aren't well, read into the whole gut health thing think of as gut health issues, but it might be presenting as a hormone imbalance, right? It might be presenting as like acne. It could be anything. So it is really, really important. Gut and hormones go hand in hand to get both looked at. I know that it can add up in costs at times, but when in doubt, I also usually suggest let's start with gut. Let's start with diet. Let's start with gut. All of that fun stress, Is there anything else with progesterone that I, like big picture, am missing that you think is the cat's meow about progesterone?
The cat's meow. Well, I think because it relates back to ovulation, anything that disrupts ovulation. So I talked about stress in the very beginning, and we've mentioned prolactin, but like thyroid, like there's a lot of reasons to basically knock ovulation off the pedestal. And once you do that, you decrease progesterone. So what we find is a lot of patients are like, oh, should I go on progesterone? Should I take progesterone? Does that mean I should take progesterone?
Yeah.
Well, depending on your age and what's like, maybe we should find out the why. Let's get to the root cause. Why don't you ovulate? And let's back up from there. Because if we can get you ovulating, then you're going to make progesterone on your own and you won't need progesterone, the hormone, because your body just naturally makes it. So I do want people to realize I do love progesterone, big fan of relaxation. Hello. But you make it through ovulation. So let's back up a step and see, why aren't you ovulating? And let's figure that out.
Yeah. What are some main reasons that women might not be, that they might not be thinking about, that they could talk to their practitioner about?
Yeah. So besides what we've already mentioned, so stress, prolactin, thyroid, are a big one. Like, assuming like breastfeeding, pregnant, or on the birth control pill, like those would also make sense. But some other big ones are like under eating or over exercise. I had a comment from a woman who said she does spinning class in the morning and she does the full HIIT workout in the evening. And she wanted to know if that was too much because she had been really affected. Her cycles were starting to be affected and she wasn't sleeping as well. And I was like, yes, yes, that is too much. Your body was like, wow, way too much exercise. You're stressing me out, and let's affect fertility. So that's a big one. With the under eating part, we used to say, especially like we used to say underweight, but it's not actually underweight. It's actually under adipose, under fat tissue, under fat percent. Because you can look at look at gymnasts, right? Look at gymnasts. They're not generally underweight. They're solid freaking muscle, but because they don't have a lot of body fat percentage on them, then they're not getting the signal to the brain that they have the reserves to have a period. Your fat tissue actually releases a hormone called leptin that lets the brain know it's about energy expenditure, but also does she have reserves that if she were to get pregnant, she's going to be fine for 9 months. So this is often why those really low body fat percent women tend to lose their period or have very long spaces in between from period to period because they're missing out on that. And usually the first thought is, oh, put them on the birth control pill, put them on the birth control pill. When I'm like, well, let's back up and figure out, why did they lose their period? Oh, because they're overtraining or they don't have enough body fat on them.
I have a few people like this right now too, which I find is a really hard place to be, that are exactly the person that you're talking about, right? And they're well aware, right? So they're underfed, over exercising for an extended period of time, and they're no longer in that space, but the hormones did take the hit for all of this. So right. So now they're really trying to work on nourishing themselves, still exercise, but have it be in a more reasonable level. But they start to gain weight potentially, right? So and then they don't feel like they're in their body. So there's this weird double-edged sword of women who are that person. They're trying to come away into this healthier state, but they feel unhealthier and not just mentally, right? But unhealthier as their hormones are shifting. So do you have any advice for those women that are kind of struggling with almost the refeeding of the body and
Yeah, for sure. Now I'm not an expert, so I usually refer them. So that's my advice, is to seek. It's not uncommon, and it's because the body is trying to come back into balance, but it's not the balance that you necessarily right? When you look in the mirror and when you used to be 4, 6%, 8% body fat, and now even you're coming up to 12 or 15%, that can be hard for a lot of women. And I understand that. And so I'm generally referring them to a coach or counseling, or even, an appropriate a dietitian to, if they're not already, to really help work with them, because going from 8% to 15% to maybe you and me is what's needed from a health standpoint. But I fully understand where they're coming from.
Me too.
That is hard mentally to watch that in the mirror. I get that.
Yeah.
But I'm not trained enough to know what to say or what to do. And I have a history of anorexia, so I can fully empathize with them. But I often send for better professional help than me.
Yeah, I absolutely agree with that. And I mean, there's also, I think of that too, though. I feel like I'm experiencing a separate type of this of breastfeeding, right? With the hormones being off, and you're already, right, for not everyone, but many women gain a lot of weight and it's hard to let go if you do decide to breastfeed and the hormones say, especially with the progesterone in play. Right. So I do feel like it's really hard, right? Where you're talking about physically and medically needing to stay in this realm of whether it's body fat, whether it's progesterone levels, but you're mentally, it's just not working for you to see your body shift like that. I always I'm I feel it. And you can't really, it's hard to lose weight or feel like you when you have to do something for great.
And even getting pregnant, right? Even getting pregnant for a lot of women, they are very excited to be pregnant, but then the physiological changes that their body shape is happening can be hard. They're so excited to be pregnant, they forgot, oh, right, I'm growing a human and it's going to change my entire shape of my body. And
Yeah.
I know that can be rough for some women. Just
Yeah.
like you said, just like on the other end, you're breastfeeding and you're in, transitioning the other way
Yep.
can also be,
You're
and,
like,
and then
"It's not working
society
out,"
and
but it's
social
not.
media is so terrible that they're like, you
Yeah.
haven't snapped back in 2 weeks. What's wrong with you? I'm like,
Yeah.
oh, let's flick you in the head.
A lot of women, that is something important. Like they don't lose the weight until after they stop breastfeeding due to
Yeah.
balance.
Yeah. And it's commonly, it's always pushed like, oh, breastfeed, you'll lose all the weight. If you breastfeed, you'll lose all the weight.
Like it comes off. I'm like, that is not, I know more women
Nuh-uh.
the polar opposite of that
Mhm.
hormone balance than, yeah, they're like, it just comes right off. And you're like, okay, we're different people. We're
Okay.
not the same human here. But I thought that was important. Another thing, right? So just, I'm kind of ranting here, but I just have want to know your thoughts on maybe the last thing is, so right, what the reason women experience acid reflux and indigestion in pregnancy is due to hormones, right?
Yeah.
Just
Yeah.
about here. So when women are experiencing more reflux in their luteal phase, what is something they could do? Because I know a lot of women that experience, right, more GI changes or bloat or reflux indigestion in that second half.
So, well, first of all, they should probably get, and we said this earlier, probably get a GI workup overall, right?
Yep.
Like, let's see what's going on overall, even though it's only maybe manifesting in the luteal phase.
Yep.
Maybe you're at the tipping point of something, some sort of infection, some sort of imbalance, some sort of inflammation that with the shift into the luteal phase, with the shift in estrogen progesterone, that is now pushing you into the more symptomatic. And then when the hormones fall, so you're constantly on this teeter totter. So like, first of all, let's see what's going on and what's happening there. And then I am a big fan of, using things while you're getting worked up of like digestive enzymes or bitters or apple cider vinegar or, lemon juice and some water to help improve digestion overall. Yeah. And then I do like, I know women, they'll reach for Tums or they'll reach for some sort of antacid. And my favorite natural equivalent is called DGL, deglycerized licorice.
Yeah.
So everyone freaks out. Oh my gosh, licorice! I'm like, no. The glycerizin part, that's the active part, is removed. That's why it's called DG. It's deglycerized.
Yeah.
So it's soft and it's squishy and it's mushy. And not only does it help put fires out like heartburn, it's very nourishing as well. So whereas Tums just kills, the heartburn feeling, DGL is actually pretty nourishing as well for the cells down there.
Yeah, it's great. I mean, we use that all the time, and I agree. Looking a little bit deeper, but I just know so many women that experience it, right? Their second half of their cycle.
Yeah, but don't just rely on. Don't be like, well, clearly Carrie said take DGL and enzymes and I'll be fine. Like, no, you still have to get worked up.
Yeah,
those are just while you're waiting to get worked up or while you're waiting for the results. Like they are good interim band-aids.
Absolutely. I absolutely agree with that. So last question, is there anything like quick tips and takeaways that women should take from this specifically, right? That if they are curious, if their levels are low or they're feeling like their cycle or hormones are out of balance or this really resonated with them, some tips of things, whether it's starting places or, focuses you should have.
First of all, always believe your body. It's your body, right? So you're going to know it better than me or you or Kara, who's on this as well. So if you are listening going, that's me, I don't feel like I ovulate. I know I don't ovulate. I have all those symptoms that they talked about. Be your own best advocate and request testing. And if your practitioner doesn't want to do the testing or doesn't believe in them, it's totally okay to have multiple practitioners. So maybe that practitioner is great for your physical or great for acute needs, but they're not good for your long-term care or your female needs. So it's time to find somebody who is in more functional medicine, who's going to listen to your whole story and actually work you up appropriately. And that's completely okay. But my first, is always like, listen to yourself. Don't let anyone tell you you're crazy or it's just in your head or, that can't be possible. Like, well, if it's happening, then it's clearly possible. Mm-hmm. So
yeah,
that's my soapbox. Be empowered.
So that's my message too. It's like, there's just so much you can take control of. So we all need to start both advocating for ourselves, get guidance on how to advocate and take power, because you have more control than you think, especially this day and age. We find the labs. If your doctor, your practitioner doesn't run it, someone else will, right? Mm-hmm. So it's okay to search for the right fit for you. Yeah. But this was great. I love to learn. You've taught me more, and I just wanted to bring some light and some information to the world on the, queen of relaxation over here, because I just feel like it's so under talked about and understood, especially by the females of the world. They don't know what they're looking for and asking for when they see their practitioners. So
Yeah.
thank you so much for your time. I'll talk to you after this for a second, but I just want to thank you for your time. Always love everyone gets to experience your podcast with us. And now I'll be booking her for DHEA, testosterone.
Noted. Amazing. Thank you for having me on.